Welcome everybody. Marissa and I will be presenting today about considerations in providing therapy to the COVID-19 population in acute care. So today we're going to explain the role of physical and occupational therapies in treating the COVID-19 population, specifically in the acute care setting. We will be able to identify when it's appropriate to evaluate a patient with COVID-19 and determine an appropriate evaluation method for a patient with COVID-19, as well as describe some considerations for therapeutic treatment with this population. So this is just a quick overview of the signs and symptoms of COVID-19. As you all know, the presentation of this disease, it varies widely between patients, ranging from asymptomatic to all of the above. Being aware of the signs and symptoms is helpful as clinicians to know how patients may present differently and which symptoms are most common according to the research. And so we have the percentages listed here. So the patients we are seeing in acute care are those that are affected more severely by this virus. They're unable to manage at home and they're requiring acute medical services. And we know from research that 10 to 15% of cases are qualified as severe disease. So they have hypoxia, they're requiring supplemental O2, and that 5% of cases are developing critical illness, and that they require some sort of mechanical ventilation, high flow nasal cannula, or non-invasive positive pressure ventilation. And a diagnosis we are seeing frequently here is COVID pneumonia, and it's classified as mild, moderate, or severe. We find with these patients the chest imaging reveals ground glass opacities and a lot of infiltrates, usually bilaterally. And these are the patients that are just really deconditioned by the toll that COVID-19 has taken on their respiratory system specifically, but the research has shown that there are also systemic issues, inflammation being one, which can lead to cardiac issues. And these patients also often have elevated D-dimers, and they are at increased risk for DVTs and PEs. And so we just don't know yet the long-term consequences of critical illness. We don't have that research, but what we do know is that in order to get these critically ill patients better, that they need therapy, and that we are indicated to treat them in both the acute care setting and in their post-acute recovery.
So that brings us to discussing the role of therapies in managing the COVID-19 population. One of the presenters from an APTA webinar really posed the question best. He says, when are we adding value and mitigating harm while influencing recovery? And when are we just becoming additional disease vectors consuming PPE? This is the fundamental question from which the Baylor and White and the Mayo Clinic algorithms were born. We need a way to navigate through this population, and we will cover these algorithms later in this presentation. So as with our general medical populations, we are assisting with appropriate discharge recommendations and for equipment and DME needs. One of the difficulties that we've run into in discharge recommendations is that many skilled nursing facilities are not accepting COVID-positive patients. There may be one or two in our area. Otherwise, skilled nursing facilities are requiring 2 negative tests to accept patients. As we've seen, patients continue to test positive long after their initial test. This often leaves us with a patient who is medically stable for discharge with no immediate chance of getting into rehab, and therefore a stay with expenses incurred by the hospital. That leaves therapies to essentially rehab patients to safely return home. At times, this means advocating for more time in the hospital with therapy to ensure a safe discharge. Likewise, in acute care, we're also assisting in returning to prior level of function. With COVID-19 population specifically, we are considering cognitive deficits, delirium, neurologic sequelae, generalized deconditioning, and decreased functional endurance in their plan of care. The last thing we really wanted to touch on is overcoming bias in this population. We know based on previous research that patients on isolation precautions get less time with providers and less quality of care. And so we need to be careful of this bias and recognize that we really do have a role in this population in helping them return to their prior level of function. So next we'll talk about the overview, the clinical process of getting to the evaluation. It may seem obvious, but initially you're going to receive your order and you want a chart review. So we are checking vital signs initially, paying particular attention to when the patient was admitted, as we're often seeing anecdotally an increased oxygen requirement in the first 24 hours that they're admitted. Patients may be on room air, an overnight increase to high flow nasal cannula with increasing FiO2 percentages. Are they ventilated? So really checking on these vital signs and touch base with nursing. They might even tell you the patient has a decreased FiO2 percentage need, but they're still desaturating with bed mobility. And this can really be helpful info for initiating an evaluation. Up to this point, this chart review sounds like it could be a typical ICU patient, where we start to differentiate between a general medical patient and a COVID-19 patient is with the ICU and the floor model decision trees from the Mayo Clinic. And later we'll also get into the Baylor, Scott, and White decision model. So you can see this slide, and we are going to have available bigger handouts for your own use if you do end up needing to treat on the COVID units. We have both a floor model and an ICU model, and this is mostly to help determine if a patient is appropriate for therapy. The difference with the ICU model is really questioning the patient's intubation status. Upon admit to our hospital, COVID-positive patients are all sent to our respiratory care unit, so you could have either floor status or ICU status patients on this unit. When you start at the top of the chart, we're not really considering the 10 to 14 days that you see in step 1, as many of our patients aren't hospitalized this long, so we're picking up essentially from step 2, where we're considering, is the patient following commands, are they stable hemodynamically and from a cardiac standpoint. And as you move down the algorithm, you wonder, is the patient stable from a respiratory standpoint? With COVID-19, we're focusing a lot on the SpO2 and being cautious with their respiratory status. It's important to consider that the oxyhemoglobin dissociation curve is going to leave you with a lower oxygen level than what's being displayed on the SpO2 monitor, with the possibility of a quick desaturation and increased time to recover to a baseline. As you move down the chart, you'll see we're asking if nursing has gotten the patient up yet. This can be a challenging part of the decision tree. It doesn't necessarily feel natural to ask another provider to go into a room, and we're certainly not trying to give away the role of either of our professions. But again, we're asking ourselves the question, how do we add the most value while not becoming a disease vector and using PPE? As you ask if the patient is a 1 or a 2-person assist, you are also wanting to determine if PT and OT both need to go into the room, or if one can stay outside and do a tele-eval while the other is in the room. Finally, you'll see informative lab value and imaging trends on the algorithm on the outside to help you navigate some of the trends that you're going to see in the COVID-19 population. And again, we've got our similar ICU decision tree, main difference being we're asking if the patient is intubated.
Okay. Once your patient is medically appropriate for a therapy assessment, the second part of the process is going to be determining the appropriate method of service delivery. So this is a tiered tree by Baylor, Scott, and White that has been a helpful evidence-based tool which has helped us determine what method of service is appropriate. So looking at this tree, tier 3 on the right, you'll see 2 boxes. And on that tree, diagnosis of general medical or cardiac disease may require monitoring, but generally these patients have the lowest potential for direct therapeutic intervention, especially if their deconditioning is mild overall. Tier 2 listed diagnoses are susceptible to rapid decline. So these patients have CHF exacerbations or COPD exacerbations. And given what's currently known about COVID-19, they may have more moderate deconditioning and need assistance with mobility and ADLs. So these are the type of patients you would want to consider potentially for mixed delivery, possibly with one discipline in the room, one with telehealth. And tier 1, all the way to the left, has listed diagnoses there, a lot of which are neurological or orthopedic. And so these patients are going to receive direct service delivery regardless of their COVID status, and have potential to have severe deconditioning and require extensive levels of assistance. Okay. So this process of determining the appropriate method of service delivery just requires a bit of clinical reasoning and coordination with other disciplines at times to determine if both or one are necessary for that direct patient assessment. Utilizing telecommunication can be really helpful to decrease time overall spent in the room. You can use it to screen to determine a clinical need for therapy, to do the subjective part of your interview as part of an evaluation, and then again to potentially do the evaluation via observation with another discipline or nursing staff member in the room. I would say, the one caveat with telecommunication will be using it as appropriate, which you may have limitations under certain circumstances. If patients are hard of hearing or confused, it won't be as helpful or as appropriate. So when considering direct patient treatment, there are some outcome measures that the research has shown has been helpful. The modified Borg dyspnea scale, or rate of perceived exertion, is the patient's subjective report of their work of breathing that they rate on a numerical scale from 1 to 10. And this can help patients build a model for measurement of their breathlessness, and it gives us as clinicians a way to document it. Patients often have a lot of anxiety surrounding their breathlessness and their new functional deficits, and so this allows them to build that self-model and become a bit more self-aware of their kind of new reality.
Meeting?
There are some PT outcome measures that are coming out of New York Presbyterian Medical Center. The 5-time sit-to-stand test as a fall predictor, the 4-meter walk test for home versus community ambulation, and the 2-minute step test as an indicator of aerobic capacity. And this virus seems to be affecting people cognitively, and we find that social isolation is playing into this as well. And it's within OT scope of practice to kind of assess and address cognition. So there are 2 assessments that have been cited in the literature to be helpful with that. The MOCA assessment to determine cognitive impairment, which addresses short-term memory and executive dysfunction, etc. And then the months of the year backwards test is a delirium screen, which can often be used by physical therapy or other clinicians, having patients describe the months of the year backwards, and then 2 or more mistakes triggers a referral to speech or OT for a formal cognitive assessment.
Next, we'll get into the logistics of direct patient care. So this is up to the point where you have decided that you're going to enter the room and do an evaluation or a treatment with your patient. So we just wanted to remind everyone of the masking procedure for therapists. We do have a binder in the office near the filing cabinets if anyone needs a refresher for PPE donning and doffing instructions and further clarification. The most important piece of information that requires differentiation is if your patient is on less than 4 liters of nasal cannula oxygen, we are wearing surgical masks. If they are wearing greater than or equal to 4 liters of oxygen on nasal cannula, or they're undergoing aerosolized generating procedures, we are wearing N95s into the room. Early on, there was question as to whether to wear an N95 if exercise counted as an aerosolized generating procedure and if your patient is coughing more with you doing activity. There currently isn't research out, however, Dr. Baracco has mentioned masking the patient if you felt that was indicated as a possible solution. One other recent development within the last month or so that has been in place at Augusta Health under the direction of the CDC is that we wanted to mention briefly is that patients are transferring off of the respiratory care unit and all precautions are being discontinued after day 21 of their infection. This has been explained that the day 21 is the peak of the virus, after which viral shedding is felt to be low enough to warrant taking the patient off of precautions. Next, we want to talk about dedicating one therapist to the respiratory care unit each day. So this can give each kind of clinician a break. In the PT department, we've been even rotating through 1 to 2 weeks simply to vary the experience as well. Regarding time of day, when you want to treat the patient, we are waiting until closer to the end of the day to decrease the risk of transmission to other patients that we're seeing on the same day. This also gives nursing time to familiarize themselves with the patient, for other care to be completed to see how the patient is tolerating general nursing intervention, and for the doctors to round. We've been doing our own form of rounding in the morning or just calling via Vocera to talk with the nursing staff about the patient. This also gives the nurses the opportunity to call you when they get the patient up if it's earlier in the day so that we can evaluate from the telehealth monitor if that is indicated. One other consideration for logistics is that it does take increased time to don and doff the PPE, to locate your reprocessed N95, to talk with providers. And so if you get into a situation where the numbers of cases are increasing, this may even be something to consider when staffing. Finally, we want to talk about decreasing foot traffic in the room. This is a large reason why we started using the Baylor and White algorithm. We really want to make sure that we are being stewards of our resources for PPE and also decreasing the spread of infection. Finally, if there's something that you can assist nursing with while you're in the room, if you can assist the patient to the bathroom, all of these are ways to decrease the risk of infection and also prevent wasting of PPE. As far as activity prescription goes for patients, it seems sort of obvious to start with low-level tasks and to monitor vitals and subjective responses with gradual progression as tolerated. But this really is not a population that you want to push, especially right away. Again, we just want to emphasize the importance of monitoring heart rate and SpO2 as well as respiration rates during your sessions. There will be days that patients wax and wane in energy levels and therefore their functional ability. There's also an element of breathlessness that can be exacerbated by feelings of isolation, fear, and even loneliness. So these are considerations you want to take forward in treating a COVID-positive patient. And finally, we've listed our references, as you can see. Thank you.